A4M is delighted to welcome a true disruptor in women's health, clinician, healer, educator, and fellow of the American College of Obstetrics and Gynecology, Dr. Suzanne Gilberg. Dr. Gilberg received her medical degree from the USC School of Medicine in 1996 and completed her residency in OBGYN at Cedars-Sinai Medical Center. Since then, she's become a nationally recognized voice in women's health and integrative medicine. You've likely seen her in print, online, and on television, where she serves as the chief medical correspondent for The Drew Barrymore Show, bringing evidence-based women's health to a mainstream audience with clarity and compassion. She is also the author of Menopause Bootcamp, Optimize Your Health, Empower Yourself, and Flourish as You Age, a book that reframes the menopause transition as a time of possibility, agency, and long-term health optimization. Dr. Gilberg is the Chief Clinical Officer at Monarch, a company that helps physicians deliver high-quality, membership-based care models in women's health, bridging clinical excellence with new models of access and continuity. Her integrative foundation is deep. She completed a clinical Ayurvedic specialist degree at the California College of Ayurveda in 2010 and was board certified in integrative and holistic medicine in 2008. She practices in Beverly Hills and is co-founder of Cedars-Sinai Medical Center's Green Committee, reflecting her belief that health extends from the individual to families, communities, and the planet. Please join me in welcoming to the main stage Dr. Suzanne Gilberg.
Good morning, everybody. I was not expecting that video montage. How are you guys doing? Are you awake now? Are you a little stressed? Not too much stress. Okay, great. I'm so excited to be here. I do have to start with a story. In the early 2000s, something called the Women's Health Initiative was published. I'm sure you are all aware of the hubbub that caused. I was a freshly minted OBGYN. I think I probably had just done my board exams. And I knew what I didn't know. And so I came to the early iteration of A4M to learn. And it's wild to me, and I am deeply honored to be here on the main stage today, all these decades later. So let's get into it. I love that Dr. Maloof just talked about xenohormesis, because we're going to talk now about how we can leverage the plants. So we're going to talk about the roots of resilience, and we're going to talk about the evidence-based uses of herbal protocols as a gateway to longevity. Let me just start by saying I am a board-certified OBGYN. I am integrative medicine and menopause expert. I use hormones. I love hormones. They're amazing. But I also love the plants, because the plants are where we got our original medicine from. So I want to kind of get into that a little bit. This is my disclosure statement, not that interesting. We're going to talk about our learning objectives, okay? So we're going to try to recognize the scope and scale of botanical medicine and how we can use that in midlife care. We're going to apply that evidence framework for evaluating these botanicals with quality and safety. We're also going to understand the concept of epistemic humility. Have you guys ever heard of that? We're going to talk about that briefly. It's very important to me to frame this in a larger cultural context. And we're going to talk about how that shapes our integrative practice. We're going to identify the evidence-based botanical protocols that we can use across 5 clinical domains, okay? Brain, bone, cardiometabolic, mood and sleep, and sexual health, because that is extremely important. And we're going to recognize the critical interactions between pharmaceuticals and herbs that we need to be aware of when we're using this botanical medicine, or even just when we're talking to our patients. I'm not expecting you guys to walk out of here and now you're doing herbalism. In fact, that's probably not a great idea if you've never done it. But at a minimum, you need to be aware of it, and we'll talk about why. And then we're going to look at how we build kind of stacked, individualized, precision medicine-based protocols for our patients, okay? Oh, here's the why. There's a huge gap in often what our patients are telling us and what we know, and also what they know. So if you look at menopause alone, we know that women are having these symptoms. 90%, that's ridiculous. It's 100% of women have effects of their menopausal transition. But up to 80% of them are using complementary and alternative medicine without any guidance. They just are dipping into that, and I think we know why. They're not getting enough attention. We as clinicians often don't have enough time. I feel like maybe that doesn't apply quite as much to this group, but we have a crisis of communication. So they're, doing what they need to do and taking care of themselves, so they think. The problem is they're not telling most of us. So up to 68% of women report that they have never discussed this with their clinician. And that's a big problem, because when you look at the data on what we know even, it's very, very minimal. Most of us are not getting any of this training formally in our educations, and there's some interesting statistics out there about what kind of clinicians understand or know or are aware about herbal medicine. And if you look just at physicians alone, and these numbers are pretty standard across the board of all licensed clinicians, less than 1 in 4 of us really have any training or understand. Look at men, the numbers are actually similar and rising. Men's use of botanical medicine is rising, and you can see the numbers below. About a third of them are using it for back pain. Almost half of them have chronic conditions, and the total percent of men in the last 2 years is rising up to 37.5%. So our patients are using this, and we really need to know why and how we can at least address it. So I wanted to head into briefly sort of the culture about this. It's very, very important for us to understand. The concept of epistemic humility is very, very important in integrative medicine. Basically, I'm going to read this for you. It's the recognition that our current frameworks for evaluating evidence are not neutral. And I'm going to say that again. I feel like this room gets it, but it's extremely important for us to understand the culture our patients are living in and the culture we as clinicians are living in, right? That kind of binary, either or, this is good, this is bad. Do you guys know what I'm talking about? You're living that reality probably. A lot of judgment, a lot of shutting down our frontal lobes and critically thinking. Epistemic humility asks us not to do that and to understand that the frameworks within which we were taught and we are currently functioning are not neutral. They reflect cultural, historical, economic context, and it's asking us, this humility is asking us to hold the scientific rigor and intellectual humility simultaneously. I feel like I'm preaching to the choir, but I really want to validate that that's why we're here learning, and that's why it is called the practice of medicine. It is lifelong learning. So the tenets that I want to touch on here are that traditional wisdom is data. Everything is not an RCT. Observational data is data, and thousands of years of use is data. People's lived experience, indigenous medicine, is data, and we should take it seriously and have respect for it. Who funds the research? Guys, I'm not a crazy conspiracy theorist, okay? I just want to say that. I am board certified OBGYN. I practice in a largely conventional setting. I grew up in convention. I've always had an open mind and heart. But think about where the research dollars are coming from, because those priorities will be funded and those agendas will be advanced. Plants cannot be it cannot be made into money in the same way as other products can, right? And the absence of evidence does not equal evidence of absence, okay? We have multiple ways of knowing. I've talked about that already. Patient experience, cultural experience, historical experience is very, very important. And I know I'm going off on this because it's really, really important. So I'm not going to go through this whole list. You have your slide set. I ask you to relax. Listen, you can look at it later if you want. Although if you're like me, I download these things and never look at them. So we'll just absorb it. Just absorb it. It's Sunday morning, okay? What I will say is this. What it is applying the same critical thinking to both integrative and conventional medicine, okay? We have to think about the mechanism of action. We have to think about what kind of evidence we have. Some evidence is great, some evidence is not so great. It's about being honest with ourselves and the person across the desk or the table from us about, yes, there's evidence. It's not the best evidence in the world, but it's got what we got, okay? We have to, again, recognize that everything is not going to be a randomized controlled clinical trial, right? And we have to understand that population level experience is a signal, okay? And we can say that things are promising and need more attention. It's not abandoning scientific rigor. It is not abandoning standards of evidence. It is not treating all approaches as equivalent, and it's not dismissing or deprioritizing conventional therapies. As I mentioned, I use hormones, right? But we're going to talk about herbs today because we love them. Okay, this is one of my favorite slides, and I'm not going to spend a lot of time on it. If you have not done any reading on the history of medicine, I really ask you to. You can also follow my Substack because I talk a lot about this. How many people here know about the Flexner Report in 1910? Okay, briefly, the Carnegie Foundation and some other large organizations funded by the early American Medical Association sent Abraham Flexner out to evaluate medical training in the United States, which is really an important thing because it was truly the Wild West. The problem was that based on their biases at the time and biases that have now been baked into the system, it wound up really closing down opportunities to continue to advance education and science in the more traditional methodologies. It also favored the more modern therapies and the more pharma kind of based, diagnostic pathology based learning rather than whole systems learning. So what ended up happening was part-time medical schools, which I didn't even know existed, which is where women were training because they were shut down. 5 out of 7 black medical colleges were shut down. Midwives were shut down. Herbalists were shut down. Okay, you get the picture. And the RCT was now the gold standard. So these things don't come from nowhere. And our thinking as clinicians is heavily influenced by these. So if we just understand where they come from, we can kind of step back and maybe rethink some of the way we look at the world. All right, so let's get into it. You all know about this, the supplement landscape, DSHEA. I'm not going to spend a lot of time on this. This is a massive amount of money. The FDA, for what it's worth, does its thing, but it looks at pre-market, whereas DSHEA, which is where the supplements and the plant world comes in, looks post-market. So they're waiting for the problem to happen. And I think the couple of things you need to understand when you're looking at using herbs and supplements is we do have significant problems because of the way things are regulated. It's not that they're not regulated, they're regulated less rigorously and differently. And so our primary issues become adulteration, products being part of what you think you're using that you didn't think, like, for instance, sildenafil in a, quote, herbal product for sexual health. I mean, that's not an herbal product. Or contamination, which can be significant, especially when you're looking at plants that were grown or manufactured outside of the United States. So things like lead and mercury. And the other problem is labeling, because people just make stuff up and, you know, what you think is in there, what the dosage is not there. So you always want to make sure things are third-party tested. You want to make sure they're produced in a certified facility and that you can get that certification if you request it. And also there are very standard formulas that have the data to back them up. Okay, so I wish I could go through all of this. What we're going to do is a little sampling. Obviously, I'm not going to tell you all of botanical medicine for brain and cognitive health. We would be here all day. And I'm sure you have other things to do. Okay, so let's look at a couple of important herbs that we know have data and how they work. If we look at, and I'm going to divide these into men and women, just because that's where the science lives. So no, you know, obviously this does not apply to gender identification. This has to do with biological sex. So when we know that we have shared pathways here, right? We are losing sex hormones as we age. And these are very neuroprotective. So this is a very important moment in time. The same botanical applications are going to be for men and women, but they just have a little bit of a different background. I'm not going to go through this busy slide. Again, you can look at it later. But the main issue for women, obviously, is hormonal fluctuation and then ultimately withdrawal completely from estrogen, which has a really big impact on cerebral glucose uptake and metabolism, we know that neuroprotection declines. So we know that women are having things like brain fog, word finding. Half of my patients think that they have dementia. Most of them do not have dementia, but it is very, very impactful and can be very serious. But it also is a signal for dementia risk, because we also know that 2/3 of Alzheimer's patients are women, and that we don't really understand exactly how this works, but we're starting to get more interesting imaging from people like Dr. Mosconi, who has shown decreased metabolism of glucose in the brain in imaging, and this increases the amyloid burden, which is very, very different than age match control in men. So there's something specifically happening in women's brains. That loss of estrogen represents a loss of antioxidant activity and increase in oxidative stress. For men, it's similar, but because men's testosterone does not fall off a cliff like women's estrogen does, it's a little bit of a slower decline. A third of men, or a third of Alzheimer's patients are men, and actually they have a more rapid decline and they have higher mortality rates. But it happens at a slower rate, and it happens largely under the influence. There's obviously a lot of other factors here that we don't completely understand. But testosterone, recall, aromatizes to estrogen. So that definitely has an impact on men as well. So what are some neuroprotective botanicals? These are agents that we know have evidence to support their use. We have ginkgo. Ginkgo works by increasing cerebral blood flow. It has antiplatelet activating factor activity, and we actually have some good randomized controlled trials in memory preservation in adults, okay? If you are working with a patient on a blood thinner, this is a big no, all right? And we'll get into some of the details of herb interaction at the end. Bacopa monnieri, I love this one. This is a really important Ayurvedic herb. It's commonly called Brahmi in Ayurveda. And this works via saponins called bacchosides, which have specific impact on the hippocampus in dendritic branching. It also has some anticholinergic activity, so that's an obvious Alzheimer's target. And it modulates the HPA by decreasing cortisol. So very, very important. This herb is used widely in Ayurveda for stress management as well. Lion's mane. I mean, a fungus is not a plant, right? But it's botanical. It's in the botany world, and I love me a mushroom. So the lion's mane data is not quite as good, but it is very, very interesting. It's been used in traditional Chinese medicine for millennia. So there's some significance there. And we think that it's working through nerve growth factor stimulation and supporting neuroplasticity. There are some pilot studies that are showing some interesting data. And finally, we have the polyphenols. So we have the extracts coming out of green tea and resveratrol. And these are, here, this is why it's important to talk about this. A lot of this data is in Drosophila. Okay, it's in flies. Guys, we just have to understand that, you know? So there are some observational data as well, but we know how these work, decreasing cardiovascular risk, which also decreases inflammation, which of course has a direct impact on cognitive function. All right, bone health, very, very important. Bone loss at midlife affects all of us. This is maybe the one area that women get a little bit more attention. I mean, okay, maybe there's a little bit more data for women here, and that's about it. We know that the lifetime risk of fracture for women is 50%, but we also know that 1 in 4 men over 50 will also suffer osteoporosis and potentially a fracture. And we know the data on mortality in the first year following a fracture. It's very significant. This is very, very important for us. So again, this is being driven by estrogen loss, which impacts directly the rankle upregulation and osteoclast activity. We know that we lose a significant amount of bone loss just in that first 5 years after the final menstrual period for women. Again, this is a slower decline in men because the testosterone is declining slowly, but it's via the same pathway. And I think it's very important to understand that the other impacts of aging, vasomotor symptoms, sleep disruption, these things have an even greater impact because they're putting women at risk. They are more vulnerable for a fall and for a fracture. So I don't think I need to explain to you why this is important. For women, we're really looking at things like the isoflavones, which have estrogen beta receptor activity, and that is bone agonistic. And it's also very important because it's likely breast neutral. I think everybody at this point understands that estrogen does not cause breast cancer, right? We understand that? Okay, just a reminder. So these herbs, you need to use them in caution with people who have had estrogen receptor positive cancers in consultation with other knowledgeable clinicians. However, I just want to remind you that these things generally are not, they're generally breast protective, okay? So that's what we're looking at in women. In men, we really just need to understand that it's a risk factor for them, and they're much less likely to get a bone density scan at all. Women are getting bone density scans way too late. In your 60s, you already have osteoporosis, but men are not getting them at all. And so it's something to really be thinking about in somebody who's been under chronic stress, using steroids, other risk factors. Okay, so the interesting thing here is that the gut-bone axis, who's heard about that? The gut-bone axis is a very powerful tool that we can leverage, and specifically L-reuteri has been studied in both men and women. So I wish I had more time to talk about this, but I will just get to the bottom line here. L-reuteri has a very important impact on rankle activity, right? When we see dysbiosis, we see increased rankle activity, we see increased bone loss. When we add in Lactobacillus reuteri, in this particular trial, which was recent, we saw a 50% reduction in bone loss over a year. This is a pretty good study. It's not a huge study, but it's a long-term study in terms of these kinds of studies. And so again, we're decreasing rankle activity, we're increasing butyrate, short-chain fatty acid production, we're decreasing dysbiosis in this way, we're decreasing inflammatory cytokines, which are contributing to the loss of bone. And I will say the L-reuteri data is more in women, but it's very, very possible that it would be working like this in men. For men, we really want to look at isoflavones, which also have other positive impacts like decreased prostate cancer. Okay, I'm going to fly through these. Cardiometabolic health. I think we know the problem with cardiometabolic health. The issue between men and women is that it is the number one cause of death in men and women. In women, we don't have the head start on that that men do. We start later with our risk, but our risk proceeds quite rapidly without any kind of intervention. So again, I'm not going to go through all the changes in our lipid profile. I think you guys all know that. But what we're looking at targeting here is something called the AMP-K activation. And I'm going to go through the herbs and spend more time on the herbs maybe than on the mechanism of action here. We're looking at lipid management. We're looking at the gut microbiome. This is important also for men. We're looking at targeting things like mTOR, AMP-K, and GLP-1s. Okay, so we know omega-3 fatty acids have a positive impact here, and you're really looking at this person who needs the triglycerides and inflammatories lowered. Okay, inflammatory marker lowering is a very important reason why you would reach for omega-3 fatty acids. Bergamot is interesting, as is garlic extract. It's kind of fallen out of favor. The data is not quite as good. This is really looking for somebody with statin intolerance, but very, very mild dyslipidemia. I mean, the data is not as good. You're going to get a reduction in your cholesterol levels, and your LDL specifically, that's much less profound, but it is an option. Berberine has great evidence to support its use. We're looking for both men and women, and it's very relevant specifically in insulin resistance. This is one that I use a lot clinically, and it's very, very well tolerated. And finally, we have CoQ10, which is technically not plant-based, although it can come in some foods, asparagus, some nuts, things like that. And just as a reminder, we should always be replacing CoQ10 when somebody is on a statin. Akkermansia, I think there's a lot of talks on this during this conference. I won't spend a lot of time, but Akkermansia data has been exploding rapidly. Very, very interesting. Akkermansia obviously is not in and of itself a botanical, but it is influenced by our diet, right? It's a gut issue, and anytime we have a gut issue and we have loss of akkermansia, loss of the mucin protection, we're going to have loss of short-chain fatty acids, we're going to have more dysbiosis, and we're going to have leaky gut, which is going to cause inflammation and have an impact on our cardiometabolic health. Fiber, prebiotics, these are plant-based, extremely important, and the data is actually pretty good, especially when you're talking about combining these with some of the other herbs like berberine. And we see this data is pretty convincing, again, smaller studies, but pretty convincing in both use in men and women. So we know that we have shared pathways, right? We have the change in our estrogen levels for both men and women. We know that women baseline have a survival advantage. However, we live longer in poorer health. So women may have a longer lifespan, but without attention, they have a poorer health span. And that's very, very important for us to look at. We know that our botanical priorities are going to be more in the estrogen receptor beta agonists, where that's going to help with bone and brain, berberine and akkermansia for cardiometabolic health, and adaptogens for the HPA axis. And for men, we're looking at similar things. We're looking a little bit more at the polyphenols. We're looking a little bit more at testosterone support via some of the botanicals that can do that. Okay, quickly we'll look at HPA dysregulation and sleep. I will say that I have a beef about sleep in women. Do you know that we don't even have a screening tool for women specifically to look at sleep dysregulation and disruption? Did you all know that? All the sleep screening tools are designed for men. They get applied to women, which means we're missing a lot of obstructive sleep apnea and sleep disruption that can and should be treated in women. It's obviously a huge problem in men as well, and we know that sleep disruption has a direct impact on mood, quality of life, and cardiometabolic health. I'm just going to tell you the herbs really quickly. Ashwagandha, which has become extremely popular, but is the king of herbs in Ayurveda. And we have very interesting data on that. Saffron, which also can decrease vasomotor symptoms, which can improve our sleep. St. John's wort, which was super popular back in the day. St. John's wort is very powerful. It is essentially acting like an SSRI, but I think everybody probably knows, or you should know, that it has a very important impact on liver regulation, and so it interacts with pretty much everything. And so you really need to be careful with using St. John wort. I don't think I've ever used it in clinical practice because there are so many issues potentially with everything else, but it is something that I think patients still are reaching for and using without possibly telling us. And for men, ashwagandha, actually in Ayurveda, ashwagandha is an herb for men. It is not an herb for every single person on Instagram. It just is not. That's not how we do it. But it is very, very important for men for a number of reasons because of its impact on HPA and specifically on building testosterone. There's data on that. So it's really good for anxiety reduction specifically, and we can stack it with other herbs. We also can look at things like valerian, which can help with sleep latency and quality of sleep, and adding it into magnesium. We'll talk about that. And then broadly looking at things like adaptogens, rhodiola is also wonderful. It's a little more energizing and relaxing, so anxiety reduction. Okay, so the protocols are here. You can look at them on your own. Valerian, very, very, very interesting, very powerful GABAergic, okay? So quality of sleep can increase, but people may feel groggy in the morning, so you always are going to start low and slow. Magnesium glycinate, everybody probably should be on magnesium glycinate. Most of us are not getting enough magnesium. We know that it works by decreasing cortisol and also can help with sleep architecture. L-theanine, also fantastic, very, very good for anxiety without sedation. And passion flower, ashwagandha we talked about, and saffron, also very, very interesting. Passion flower has been used traditionally for millennia and can really, really help, especially with sleep quality without that grogginess. Okay, sexual health, 2 minutes for sexual health and vitality. I'm gonna go over a little bit, and I apologize to the next speaker. All right, this is really important. Sexual health and pleasure are our birthrights, okay? So these should not be skipped. patients frequently don't bring their sexual health up, their pleasure up. It's something that we should bring up. Often we don't want to bring it up because we're not trained in it or we don't have an answer. But it's important to create space to have a conversation. I got to tell you that I've learned much of this over the years based on conversations that I've had with patients where I said, I don't know the answer, let's work on that together. That is an acceptable and honest and humble answer, and that's how we grow and learn. So we really do need to talk about this. Again, these issues in men and women are multifactorial. There's definitely a hormonal basis to it, but it is not just hormones. Sex is biopsychosocial. How can we help? Interesting herbs with interesting data. How many of you even heard of tribulus? I don't think it's okay, great, I love that. It's not talked about as much, but it's a wonderful herb to reach for. Panax ginseng, maca, I think people know about. Fenugreek is a really interesting one. Saffron specifically for female sexual dysfunction related to SSRI use. We all have patients on SSRIs, and many of them are not talking about their sex life. Tribulus is wonderful for men and women. Maca has great data to support its use. Fenugreek also can increase testosterone in men and women, so it can be helpful because we all need testosterone in our lives. Here is a really great, this is a really good one for you guys because it's got how it's used, the summary of evidence, the protocol, the dosages, and how good the data actually is here. Okay, really quickly wanted to touch on gonadal aging, and is there a place for botanical medicine? Because this is the next frontier for sure in women's health is ovarian aging. And I will tell you, there's some interesting data, and I just listed some herbs. A lot of them are the plant polyphenols. A lot of them are actually traditional Chinese medicine or coming from traditional Chinese medicine. And this is preclinical data, everybody, preclinical. We have no RCTs, but they're interesting. They're interesting. We know with testicular aging, I talked about ashwagandha, turns out there is data on it. So Ayurveda was right. The rishis, the sages who brought this knowledge to us 5,000 years ago, we're onto something that we now are starting to prove. Just like they talked about the gut and the microbiome, oh, what do you know? There's data. So these are a couple of really interesting options to reach for. This is a wonderful resource for you all, herb-drug interactions. Not going to spend time on it. And we'll just end with this. How do we build our protocol? We assess. I will tell you that using some of those assessment tools in your EHR can be very powerful because when you look at it yourself, you really understand the profundity of the impact it's having on your patient. There's nothing that's going to replace the conversation and hearing their story, but I'll tell you, doing an assessment and then coming back later to reassess and evaluate how are these protocols working is very helpful for you and for the patient because they can see, did this work, did this not work? Oh, wow, there's a change here. And that's very important to help validate them and build trust in the relationship. So we do an assessment, we prioritize. We're not doing everything at once. What are your top 2 goals or 1 goal at this visit? We layer on. We go low and slow and layer on every 6 to 8 weeks at most. If you overwhelm someone, they're not doing any of it. That's not helping anybody. Again, monitor with reassessment tools and definitely with checking in, and then maintenance. So I think the other thing to think about here is setting expectations that are realistic. Herbal medications are not pharmaceutical. Some people, the first night with valerian, are going to sleep through the night. A lot of people, when you're using these herbs, are going to notice no difference because they didn't know their LDL was going high. But if they're taking 6 to 8 weeks, that's normal. I always tell my patients when I start an herbal protocol, don't expect a big change. This is not Tylenol, all right? So you got to really be in conversation, and it requires that continued conversation, that continued relationship. So I'm 1 minute and 44 seconds late, and we're going to close our top 10 pearls, right? Quality is always going to be more important than the dose. If you dose out the wazoo and it doesn't even have what you thought was in it, obviously that's not going to do anything. We're going to set those realistic timelines immediately at visit 1. We're going to look at multimodal, starting with one herb and adding in lifestyle, breath work, sleep, all these other things. That's always going to be the most powerful tool. We're going to screen every patient at every visit. Are you taking any supplements? Are you taking any new meds? Are you taking anything that you bought on your Instagram feed and didn't realize that's a quote medicine? We're going to be honest about the evidence. We're going to start low and go slow. We talked about that. We're going to always check for St. John's wort. I don't know, that's a little extra, but I'm going to say it anyways. We're going to remember that the lifestyle is the foundation always for everything, and we're going to match the botanical to the mechanism. Last, we're going to document everything because people are crazy, and your colleagues are probably the craziest. I said that. Not your patients. Your patients are awesome. And this is just a little way to end. We want to remember that this comes from traditional medicine. We want to honor that. We want to embrace evidence where we can. We want to have a culturally sensitive, patient-centered approach always. And we want to expand our toolkit by being curious and humble. I want to thank you for listening to this and for the speed date that this was. I hope it really helped you become more interested in learning. And these are some ways you can find me. I'm online. I've got a Substack. I got an Instagram. And I'm also proudly the Chief Clinical Officer of Monarch MD. If you have any questions about this data or how to use it or what I'm doing, please come find me. It has been such a pleasure. Thank you so much.